Assalamu alaikum.
I'm Slamson. How's it going? You're right.
Yeah, good, thank you. Thank you so much for joining me today,
Not at
tonight.
all. Pleasure to be here.
Yeah,
Thanks for having me.
you're very welcome. So we're doing this live today to talk about you and your career in podiatry. So first of all, I'm going to say how we met and how have become connected. So should we talk about that first?
Absolutely, go for it.
Yeah. So you know my little sister, and that's how we met. Basically, she told me about your journey and what you've been up to. So I want to give a big shout out to Miriam for connecting us.
Absolutely. It's a shout out to Miriam. Miriam and I trained together at university. Miriam was, I think, a year above me. And we've remained pretty good friends. And she was like, well, I've got testicles, Zainab as a GP. I think you two should get in touch. And here we are. So yeah, shout out to Miriam. Absolutely.
Yeah, she just said hi as well. She's excited. She's on live.
Oh, there she is.
So I know there are people on the live that may know who you are. So, but just explain to those who don't know what you do, your job, and other titles that you have.
Sure. So my name is Usamah. I work as a podiatrist currently in private practice. I'm also a member of council and director for the Royal College of Podiatry at the moment, and that looks at the strategic direction of what we do as an organisation. Currently working in private practice and sort of deal with all things lower limb related, to be honest. It's been quite enjoyable so far. 5 years since practice, so I qualified 2018 from the University of Northampton and went straight into private practice initially. Did some work with the NHS and then gone back into private practice. So currently I work in two private practices. I do a 6-day week clinically,
Wow.
quite tiring.
Yeah.
And also alongside all the other stuff I do, from conferences to committees, national talks,
Wow.
the list goes on. So it's a pretty busy time really, but yeah, quite enjoyable. It's pretty good fun. I quite like it.
Yeah, I had a few questions for you because obviously being a GP, we refer to podiatry quite a lot. Some
Yeah.
of our referrals do get rejected, and I don't know whether that's not having knowledge about what it is that you guys do, or whether we sometimes get told, can you refer to podiatry, for example, and it may not be the appropriate pathway.
Mm.
So, first of all, I wanted to ask, how did you and why did you go into podiatry initially?
Well, getting into podiatry, to be honest, was through my brother's friend, shout out to Galal actually. He got me in, and he was a podiatrist at the time. And he was like, "So, have you thought about doing podiatry?" I thought, "No idea what that is." But he's like, "Come along, and we'll go out for a meal." So we did. And he was a podiatrist at the time, told me all the things about podiatry. So I thought, you know what, this career has got legs, as it were. Sounds pretty good to me. I quite like the postgraduate sort of opportunities.
Yeah.
So I'll jump on and yeah, applied for it, and here we are now. I mean, he sadly has left podiatry. He's always
Wow.
had to
Okay.
sort of leave a jewel in the crown, as it were. And
Yeah.
he's gone into teaching.
Wow.
So he's
Okay.
helping other people out, so he is forgiven. But it's sad to see him go.
And so you qualified back in 2018.
Yes.
How long is the podiatry course?
It all depends on what route you take, really. So I was
Mm.
a school leaver, so I went straight from A levels, as it were, into podiatry, and I went through the 3-year program, the BSc honours at the University of Northampton, and then went on to do my masters at the University of Huddersfield part time. So that was an additional 2 years. But so multiple routes exist. So you've got the 3-year program at the moment. You've
Yeah.
got a 4-year program with a foundation year. You've also got the accelerated 2 years pre-registration MSc program that's eligible
Oh, right.
for anybody who's already got a degree looking to get into podiatry thereafter, and they can get in via the 2-year program. It's the same content as 3 years,
Mm.
just condensed into two, so they have fewer holidays. You've also got the apprenticeship scheme that goes out as well,
Yeah.
and that's sort of earn as you learn. You're still attached to a university, and they sort out your exams. You still qualify with the BSc honours in podiatry. So multiple routes, always
Yeah.
looking to increase accessibility into podiatry, but keeping that rigor with it.
Yeah.
So multiple ways of getting in touch. And as far as I'm aware, medicine for the first time ever has
Yeah.
gone for an apprenticeship scheme this year too. So it's all
Mm.
about really getting more people, more bodies on the ground, making that access into healthcare
Yeah.
that bit easier for people from communities who may typically not think about a route to get into medicine, a route into podiatry, or any other AHP profession. So I'm
Yeah.
all for it. It's all about bringing more people in and making it as accessible as possible.
Exactly. And giving more opportunities, different career pathways where you can still be helping people And I know you have to learn all your anatomy of the lower limb. And you do, I mean, we refer people who have toenail, ingrown toenails and problems with their footwear, or they might have corns or bunions, but you do a lot more than that. Your day is very much varied, but it does depend on whether it's private practice or NHS. Is that right?
Ish, kind of, yeah. So, I mean, I think typically the sort of public perception of it all tends to be, well, podiatrists just do routine care all day long, and that's all we do. There's so much more to keeping the nation marching forward, as it were. I mean, yeah, the routine aspect is really important. The preventative care, keeping people mobile, keeping them active, is a big part of the job, and that's what we do. But so much more than just that. I always say to students as well is, the feet you're looking at are attached to a person, and
Yeah.
think of that patient more holistically.
Yeah.
So all the systemic diseases you can possibly think of will will present on the lower limb. So from cardiac issues, so someone's got ischemic heart disease, they'll likely have lower limb ischemia, peripheral
Yeah.
arterial disease, all them sort of things we're picking up. Stroke patients and their gait changes, all that comes through our way as
That's true.
well.
Yeah.
MSK pathology, so knee pain, shin pain, hip pain, all sorts come our way, as it were. Sports injuries, diabetes. I mean, in particular, today's World Diabetes Day. So
Yeah.
it's important to shout out about what podiatrists do when it comes to the prevention of diabetes and its diseases on the lower limb, on the foot and ankle, and also preventing and reducing our national amputation rates as well.
Mm.
I mean, every 20 seconds, someone somewhere loses a limb due to diabetes.
Yeah.
It's a big part of the job. But then you got all your elderly care as well, all your sports injuries, your pediatric care, so much more. Then that's just the clinical side of podiatry, as it were. Then there's a lot more from research, academia, leadership, a really varied approach to the whole thing, and just trying to
Yeah.
get sort of people to realise that there's so much more to it than meets the eye.
Yeah.
But you're right, going back to the differences between NHS and private practice, some of your scope will depend, depending on what sector you're in. I think at the moment, from a post-COVID perspective and COVID recovery perspective, the NHS does a lot of focus on high-risk wound care, and diabetes care in particular, understandably, because that level of risk
Yeah.
is needed in an NHS setting. Privately, I don't see high-risk wound care. Typically, if someone's got their toes hanging off, they don't need to be in a private community clinic. They need to be in the NHS with an NHS MDT as per
Mm.
NICE guidelines. So that's the right place for them.
Yeah.
But sort of privately, we see sort of everything that comes our way. We're never really too sure what comes through our doors. People
Yeah.
tend to self-refer. So that scope will vary a little bit because there's so many different facets and specialisms they can go into. So
Mm.
it's a really varied day. It's quite interesting, actually, yeah.
Yeah, and you have to have some surgical skills in there as well, and
Well, initially, as part of your BSc honours, some minor surgery, so things like ingrown toenails, nails and soft tissue surgery, but you can definitely progress down to bony surgery, as it were, so into podiatric surgery. That was my master's back in 2018 at the University of Huddersfield.
yeah,
Whole pathway linked to it as well. So you do your master's, do your surgical passport, start your surgical practical training, and things like your specialist registrar posts,
yeah,
consultancy, etc. So it goes through that particular pathway, as with any other aspect of surgery as well in the world of medicine. So, yeah, minor sort of surgical skills at the undergraduate level that are honed as time goes on. But yeah, on the whole, it's pretty good.
yeah. And at the moment, you're in private practice, is that right?
Yeah, at the
Is
moment,
it
yeah.
something? Yeah, and how are you finding it at the moment?
Loving it. It's really quite enjoyable. I quite enjoy my private practice work. It's good fun, nice and varied. You build a really good rapport with your patients, much like being a GP, to be honest. You get
Yeah,
to see your sort of regulars quite routinely. And just keeping people active is the most important thing. But because you build such a good rapport with people over a period of time, you get to know so much more about them, about their
yeah,
lives. And
yeah,
that's where, that's a really big part of the job, because what you're looking at there is looking at that patient holistically. So we're
yeah,
getting multiple things clinically where patients aren't able to access their GP, for example. They tend to come offload on us guys. We have the luxury of time with them, so we can spend anywhere up to an hour with a patient, really. So we
yeah,
have a huge amount of time with them, and that's where being a really good detective, being a really good clinician, really comes to its fore. Picking up things like mental health issues that we're seeing, cost of living crises that we're seeing more and more commonly. Loneliness is a huge epidemic that no one's really looking at, I think.
yeah,
Patients come in this sort of way in their Sunday best because they come to see us and that's their only contact they have to anybody outside of their home for the best
mm,
part of God knows how many weeks. So being
yeah,
able to sort of reassure people, signpost people,
Yeah.
is a massive part of the job. Absolutely.
Wow. And in terms of common problems that you see in your clinics, you know, how much, what proportion of those are referrals, and what proportion of those self kind of referrals?
So currently in
GP.
private practice, we tend to get some GP referrals, not many, I have to say, because mainly they would refer into the NHS system, which is, I suppose, fair enough, but a lot of ours are
Yeah.
self-referrals. However, if you're working via the NHS, it depends on your trust and your CCG as to how
Yeah.
they accept referrals. Some will allow patients to self-refer to the NHS, others you can only be referred through via GP or AHP in particular. And it all really depends on what you're seeing. But
Mm.
either way, a referral will get triaged and they get booked in that regard, as it were. But going back to your previous question about how do referral systems work, why do they get rejected, as it were, it all
Yeah.
depends on what's being referred in,
Yeah.
especially from an NHS perspective as well. I mean, previously there's this myth that if you've got diabetes, you need routine care,
Yeah.
you've got to see a podiatrist, and that kind of was the case, and it was
Mm.
important to have that to maintain patients at routine level, at low risk level. And sadly, when COVID came along, we had to sort of cut a lot of that commissioning was cut, and it just focused on high risk wound care, rightly so, during the peak of the
Yeah.
pandemic. But of course, the backlogs are just, as you know, astronomical, and it's been very, very difficult. So the referral system would vary from commissioner to commissioner about what's allowed in. And if it ever gets rejected, you can always ask and say, well, why was it rejected? Is that something
Yeah.
that's not commissioned anymore, or has that just been a clerical
Mm.
error, or whatever it may be? So it's important to realise and get feedback as to why was that referral rejected, and what can we do to
Yeah.
ensure that our future referrals are justified and appropriate.
No, you're absolutely right. When I was training as a GP, and also, you know, when I was a medical student and we were sitting in on podiatry clinics, it was the main thing. If someone's got diabetes, they need a podiatrist because of the neuropathy, you know, that you get,
Yeah.
and the changes to the feet and things like that, and the footwear that they would need. So for me, it was like always a done deal that if you're a diabetic, you have a podiatrist. But now, unless there's a particular problem like an ulcer, or you're not seeing them now, I think, is that what you're saying?
I mean, I'd like to think that we're building on that routine caseload and
Yeah.
that preventative caseload. I'm not really too sure because I don't work in the
Yeah.
sector, and I like to think they'll be getting back to that sort of level pre-pandemic, as it were. But you're right, and often I appreciate as a GP, you tend not to refer to private clinics, as it were, and that's
Yeah.
understandable. But that's kind of where that loophole tends to exist, because patients who are unable or unwilling to go down the private route get left in this sort of field whereby they're not able to see anybody. And it's about sort of making people aware of, well, this is what we do. We can also help you to do come and see us. But I appreciate there is a financial onus there.
Yeah.
And whether or not patients are able to meet that is a different matter. And we are seeing the cost of living coming through. So patients saying, well, actually, I can't quite
Yeah.
afford to come and see you.
Mm.
It depends on how they pay. Some will be self-paying, some will be paid by the health insurance. So you got all them different facets you got to deal with too. So, but as far
Yeah.
as I'm concerned, it also brings up ethical issues too. If you've got a patient who needs some care, as it were, that's relatively urgent, but unable to pay for it, what do
Mm.
you do?
Yeah.
So it's all about sort of balancing that need, as it were,
Yeah.
against what we've got available to us. And yeah, I mean, unfortunately, it's about building and being able to allow these patients to access all healthcare services, both
Mm.
NHS and private.
And say, for example, you do have a patient who needs urgent care, but they haven't got the means to pay for it. Then how would you then refer them into NHS services, or maybe that's an option, or maybe give them a deal, like a finance kind of
Yeah,
deal?
yeah. There's loads of things we tend to offer. Either they'll be funneled via the NHS service, and if it was made, then yeah, there's various things we can do in the private sector to ensure
Yeah.
that patient gets timely and correct care, as it were, from finance deals to instalments, whoever it may be. We've got various
Yeah.
sort of things set up for them to ensure that, irrespective of the means to pay, the patient still gets seen and still gets treated correctly.
Yeah. So just generally, kind of what are the pros and cons of being in NHS or private practice as a podiatrist,
Mhm.
but also maybe sort of mix in with patient journey?
Yeah, sure. I mean, it really sort of depends. I mean, NHS, I really, really enjoyed my time over there, to be honest. And I guess as a new graduate coming out, it's a good idea to get into the NHS initially to get all your competencies sort of sorted out,
Yeah.
with your rotations sorted out, and you get a really good sort of mix and a feel of what's happening that complements your NHS placements that you would do as a student too.
Yeah.
Very different shadowing to actually sat in the chair doing the actual job. And what I tend to say to students anyway is just because you got your degree, that doesn't make you the best podiatrist going. A bit like your
Yeah.
driving license, just because you got your license doesn't make you the best driver. It does require honing that skill set, and the NHS is perfect for it really, because they'll guide you through a preceptorship program, and you have that career progression as you go up the bands, as it were,
Yeah.
which is quite nice. And that really kind of gives you the confidence boost that you need to help you through that. The patient journey aspect of it, of course, will also vary as well. Typically, I mean, in private practice, I see all my patients all the time. They only ever see me. So that building of rapport is perhaps a bit easier in private practice compared to NHS, because
Yeah.
either see your department or then move on to a different specialism. You may not see that patient again. So yeah, and the pros of private practice, I suppose, it's a bit more. Well, both are quite rewarding, as it were. I find it quite rewarding in private practice, and I guess people think, well, actually, just in private practice to sort of for that financial gain, and that's simply not true. By working in private practice and managing them patients privately, we're reducing that burden on the NHS. And that's the idea behind it. So just because you work in one sector doesn't mean we're not working towards a collective goal here, to ensure patients are seen irrespective of their need, and sort of and are triaged appropriately. I guess one con of it, however, in private practice, one thing that I find quite difficult, when somebody comes for initial consultation, for example, and let's just say, and they're able to pay for that, that's relatively easy to pay for. But let's just say they need imaging, they need bloods, they need investigations. It becomes a lot harder if the patient's unable or unwilling to pay for that down the private route. And then what you then have to do is then cross-refer that patient into the NHS, wait for all that to happen, get the results back before we can produce a management plan for them. That's where it gets a bit tricky. So when patients start private and go private all the way through, it's a hell of a lot easier. But patients want to mix the two services together, that can then create slight delays because the patients are waiting for NHS services to pick up that slack, as it were. So that can be a little bit difficult.
Yeah. And in terms of, are you also part of the Royal College as well? So when do you fit in that time? Because you mentioned you work in 6 day week, 6 day, 6 days a week.
Evenings,
So
weekends, any spare time, ultimately.
yeah,
I guess it does sound busy, and I suppose it is busy, but you get better at managing your time as time goes on. You get better at prioritizing,
yeah,
and as the saying goes, if you want something done, give it to a busy person. And that's just because you kind of build that skill set as time goes on. So my role with the college, as it were, I started off when I was a student in my second year, and I was elected as chair for the Student Association, so representing all the students across the UK, and that was my sort of first foray into the sort of Royal College, as it's known now. I've sort of kept my ties quite close with them. Of course, that dropped off back when I graduated. I was no longer a student anymore, but then got involved with the committees at a sort of local and regional level. So working with my local branch, which is the Birmingham branch, and working my way that way. And then I currently sit at the moment as vice chair for the Equality and Diversity and Inclusivity Committee, the EDI committee, which is a massive part because EDI affects everything. And ensuring that care is equitable and inclusive is a really big part of it. And I think more recently as well, one of my personal interests, tend to be things like dermatology and skin conditions. And that really kind of, the whole EDI thing really kicked off with the whole George Floyd, back in America, when that all kicked off back in 2020, as it were. And there was a real big need to understand actually what are the differences that exist, and how can we actually just bring down any differences and make it as equitable as possible. But also when COVID hit, what we then found was the Black, Asian, minority ethnic, the BAME community, which is a word we tend not to describe, but if we just use it for this instance, the BAME community was disproportionately affected with COVID. We saw larger deaths compared to other communities, for example. But why is that? And what we then found with the vaccine uptake, that was poorer in these communities compared to other communities. What we then found was a huge amount of vaccine hesitancy, not understanding what vaccines are all about. Perhaps can't read the literature because English is not their first language, and they may struggle with that. So what we then did was create videos in different languages to go out to different communities to actually help explain in layman terms what we're doing, why it's important to do that. And then, of course, my particular interest in dermatology was looking at different skin diseases and presentations in different skin tones. If you look at the medical literature at the moment, and of all our skin conditions, all of it tends to focus on sort of Caucasian skin types, as it were.
That's right, yeah.
And if you're looking at infection or disease, or infection rather, you know, red hot swollen, think infection. But of course, if you're, you know, a darker skin tone, as it were, or brown or black, you know, redness and erythema doesn't show as clearly.
Yeah.
And that's one of the sort of one of the key diagnostic criteria. And if you miss that, then you may miss your whole diagnosis there, or you may misdiagnose. But when it comes to things like skin cancer, in particular, looking at melanoma, so melanoma is the fifth most common cancer in the UK. How many cases are walking through our doors that we're not familiar with, as it were? But on darker skin tones, agreed, it's rarer compared to sort of more whiter skin tones, but indeed still possible. But the presentation also differs as well. So looking at melanoma and UV radiation, it's more common on sun-bearing skin. So, you know, chest, arms, legs, that sort of thing. But on darker skin tones, the presentation varies completely. So we're looking at soles of the feet around the anogenital region, areas that typically don't get sun exposure. And acral malignant melanoma tends to be the most common type of melanoma that we tend to see in darker skin tones. And it's all about being aware what to look out for and spotting it sooner. The quicker you spot these things, the better the prognosis, the better the outcome. And that's the idea there, generally speaking. So, but also looking at general conditions like, I don't know, psoriasis. You know, you see these sort of circular, well demarcated, red, scaly lesions typically. But again, if you're brown or black, you don't see red quite clearly. They look more grey in colour.
Yeah, that's right. Yeah.
And you know, if you're not too sure what you're looking out for, you may say, well, actually, that's not red. I was taught red. The books say red. Everything says red, but that's not red. Is that really psoriasis? And all the while, it is. And the beauty of dermatology as well is that irrespective of sort of, you know, the skin type, as it were, that diagnosis and that management plan doesn't change. So it's all about getting the correct diagnosis there. So that's the important thing, and you know, just to ensure that we're able to spot skin lesions across all skin tones, but also think of it from an MSK perspective as well. So looking at sort of the foot shape and foot structure, you know, and how we assess foot shape and structure. So, you know, if you're looking at Caucasian skin tones, they typically have more of a high arch foot, whereas brown and black people, Asian people, tend to have more of a flatter foot. And understanding how we actually create insoles and our perception of what is a normal foot, if such a thing even exists there, will vary. So if you look at somebody like Usain Bolt, you know, who just, if you look at his feet, they are flat as a pancake. You know, and you think, well, with feet like that, you shouldn't be the fastest runner in the world. Yet he is. So understanding how them sort of things vary will also be important. But looking at things like high-risk wound care and diabetes in particular, you know, understanding signs of infection in darker skin tones. And we know that being South Asian, for example, you're at the highest risk of type 2 diabetes of any other community, and being aware of all them sort of things. So it's tying it all together, and it weaves across different sort of specialisms there. But understanding sort of, I mean, when we're talking about skin tone and skin colour, or differences in race and ethnicity, it goes beyond just skin colour, as it were. It's all about the other issues that we tend to see as well.
Yeah, and are there any particular cases that stand out to you when it comes to assessing patients with darker skin, and where the diagnosis has not been done right, or any kind of skin color, to be fair?
Yeah, sure. I mean, just recently, actually, probably about a month or so ago, we had one chap come in, and I mean, this is what I've got anyway. This is a little dermatoscope.
Yeah, let's have a look.
Let's
have a look. Go close to the camera. Let's have a. That's quite cool, actually.
So it's effectively, it's very, very fancy magnifying glass, really. So all you got to do, you sort of see it on there. You've got one button here. You just switch it on and switch it off. There we are. And then what you got to do is move this around to change the focus, apply it directly onto the skin, and switch it on. And you can see it's got different sort of lights to it. So you've got polarized light and non-polarized light. If you touch it on and bring it right up to your eye, you're able to look at that lesion a lot closer. And if you know what you're looking out for and the algorithms you're looking out for, that allows you to sort of say, yep, that's benign. No, that looks a bit suspicious to me. And that's the beauty of it. So it ensures that your referrals are justified and appropriate. So we're not sort of referring every benign nevus to secondary care dermatology, for example, because they're currently struggling hugely at the moment. One recent case, we had one chap come in who's had a history of a melanoma on his head. I mean, if you've got a personal history of it, that also increases your sort of risk of future cases of skin cancer as well. And he had these new lesions across his top of his forehead, as it were, and he was like, I'm a bit concerned about these. So I had a little look at them. They were suspicious of squamous cell carcinoma, and I was like, oh dear, that's not looking very good. So we referred him across by the 2-week wait, and yeah, I got a lovely letter from the consultant dermatologist saying thank you for the referral. Definitely was justified and appropriate. So we had a little look using the little dermatoscope, took photos. You can also attach it to your phone and take crystal clear photos that way. And you can also benchmark it and put it on the patient notes and sort of assess them as time goes on. And yeah, that was confirmed by histo to be squamous cell carcinoma, excised, and he's currently going down that particular pathway as well. So it's and the consultant was like, didn't realise that podiatrists can do that. Well, skin. That's what I always say anyway, and that's why I champion it, because when patients come our way, not every patient's got a high risk pathology, not every patient's got an MSK pathology. Every patient's got skin, and hopefully should have skin. And if you're looking at skin, and if you're looking at skin regularly, you should be familiar with what you're looking out for. And then looking at precancerous lesions as well, like on women in particular, we see a lot of sort of the most common place is the lower limb. Typically, older generation of people, it's not a case that you get cancer or skin cancer as you get older. It's a case of it's cumulative sun damage, isn't it? So the older and the wiser you are, the more cumulative sun damage you've had. So looking at things like Bowen's disease, which is precancerous squamous cell carcinoma, for example, and being aware of things like that, it's quite common. And oh, have you seen that before? Oh dear, I've never seen that before. So it's a case of well, keep an eye on that, and we'll chart that progress as time goes on. Things like what's called subungual melanoma, for example. That's melanoma in the nail plate. Not to be confused with things like melanoma, for example, which are normal benign sort of pigment of melanin in the nail plate, and the darker you are, the more common they are. I've got a few in my nails, and people always say I've got that skin cancer. Famous case, Bob Marley passed away from it. He had subungual melanoma. He thought it was a football injury, and no, it wasn't. Sadly, it was melanoma, and he passed away at the age of 33. And that's why it's incredibly important that we're aware of what to look out for. And of course, if it's a darker skin tone, they're more common. So if you're African, for example, the chance of having what we call melanoma, which is that benign melanin in the nail plate, is 100% by the time you hit 50. Whereas if you're Caucasian, it's 1%. And that's the difference. So using one of these trusted little things, have a little look, be justified in your referral, be confident with what you're looking out for, and get the patient with the right referral, right time, right patient.
I think that's really amazing that you're doing the dermatology side of it as well, because I don't think a lot of podiatrists do that. I mean, the 2-week wait referral you didn't have to go through a GP. You did it straight yourself, didn't you?
It was by the GP, actually. I don't really have the
it was by the GP, but you told the GP to do it.
Yeah, absolutely. So it's marked as urgent. It's done by the GP. We don't have a pathway set up at the moment to do a direct referral to a secondary care dermatology. So that's kind of one of the cons as well. Often when you need to refer somebody on, it's again via the GP, as it were. And we appreciate you guys are busy as anything. So trying to get through our letters alongside the 5 other letters you're going to have to get through can be a bit tricky. But
so that's a bit of a shame, really. But I think we should all be connected. Whatever area of healthcare you are, you should be able to connect with whichever specialty you want to. And that's quite frustrating, because you know what you're talking about. It's not like you've had training in this, so you should have that ability to be that connection. So why does it have to go through a GP to do that? But it just saves time.
The private sector and the NHS sector don't quite marry up together, and that's one of the cons of it as well. Typically, So sometimes if you need like an X-ray doing, you're like, oh, what's the best? I mean, I had a lady in the other day actually with a really sore toe. And it could have been a number of things. I mean, my first suspicion was a fracture. The second one was a plantar plate injury. And the third one was her rheumatoid arthritis playing up. You're thinking, well, it's a bit of a tricky one with this one. What do I do? And the big red flag would be fracture. I can't really have you walking on a fracture, can I? So we're thinking, well, I was like, well, how do I get the lady seen quickly without having to wait for 15 hours in A&E? So I rang up a GP, explained the situation to him. He was quite kind. He was like, just asked her to pick up a request form from reception. She did so, went to outpatients, got seen really quite quickly. And often you've got to think about, well, actually, what can I do for that patient today? How do we get them seen to as quick as possible without sort of, with them wasting hours and hours? So it's timely care for these people.
Absolutely. And in terms of this knowledge that you've got in dermatology and this interest, where did this stem from? Because it did stem from when you first started podiatry, or
It
why
sort
did
of, sort of came about as time went on. I guess the sort of more patients you see, the more skin disease you typically see, and it's about, well, actually, it's surprising how what seems like a very banal sort of common derm complaint can get people down quite dramatically. And if you can do something about it, the more you know, the more you're able to offer. And like I said, everyone's got skin, so being able to look at it, cohesively. So, well, actually, hang on a minute. Let's have a look. Let's have a little look at this properly, and take it from there. I mean, just today, for example, had a lady with some quite severe, athlete's foot that hasn't been managed appropriately, and she was crying in the chair. She was
yeah,
really upset. She goes, "I can't do anything." She couldn't do her exercise boot camp. She was embarrassed to go out, embarrassed to walk around barefoot. It's fissured, it's sore, it's cracked, it's bleeding. Every footstep's painful. She can't drive effectively. She can't go swimming. And you're thinking, well, it seems like a very simple thing, but it gets people
yeah,
down quite quickly. And then you got to think about mental health issues that may come in, for example. Then think about, lack of exercise, poor nutrition. All of it feeds into the patient actually kind of going down a
yes,
spiral. So if you can sort of intervene in a timely manner because you know more, why not? You know,
yeah,
and that's how I see it. So if you're able to sort of assess people, reassure people mainly, that things will be well. There's a management plan for this. We can deal with this. Then it goes, smooth. So that's the bit that I really enjoy.
yeah. The holistic side of things.
Absolutely, yeah.
Yeah. And I know you mentioned that you were also, because we've had conversations before about podiatry not just being about feet, not just being about, the things that we sort of refer to you. There's a lot more to it. Tell me, what is that, so that people know exactly what you do and what it is that makes the career so varied, even though we think it's just feet. It's not actually just feet.
Well, true. It's so much more than just feet, as it were. But I think the national message here is, think feet, think podiatry. Just when you sort of think teeth, think dentistry, think eyes, think optometry. The idea is think feet, think podiatry. So if you've got any lower limb concern, foot and ankle concern, or anything remotely lower limb, go to your podiatrist, be that NHS or private, as it were. But so much more. I mean, clinically, let's have a little chat about that. So from
Yeah.
doing a basic vascular examination of palpational pulses, doing a Doppler pulses, for example. Let's go from from the feet all the way down up to femoral pulses, for example. Doing a really holistic overview is quite important because
Yeah.
you may have somebody coming in and they may seem absolutely fine, but actually, if you don't do a vascular assessment on them, you wouldn't even know. So we had one chap come in once who was triaged as an MSK patient who was complaining on the phone that, my legs are really hurting me. I can't walk very far. I think I've got tight calves and tight hamstrings and my gait needs assessing, for example. And he came on in and we had a bit of a chat about it all. And I go, well, take a seat. Let's have a little look. And we did. And actually, pedal pulses, non-palpable. On Doppler, monophasic.
Oh
Popliteal
wow.
pulses, monophasic. I went up to the femoral pulse. That was about biphasic. And I thought, well, actually, it's not it's not a muscular issue you've got here, sir.
Yeah.
It's a vascular issue. Sound similar, but they are distinctly different. And if you're not familiar, you might think, well, what we'll do is stretch out these hamstrings and calves for you, and off you get going. And ironically, walking is the best thing for it. Keep on walking, build up that collateral circulation, do an ABPI on that patient, refer to vascular. Let's have a chat about, are you smoking? Let's talk about smoking cessation, for example. All them small little things you could do that feed into that aspect of that for that particular patient.
Yeah.
So much more than, oh yeah, tight hamstrings, tight calves, and it's so much more to it than just that. And that's just one classic example, as it were. But yeah, things like pediatric care, for example. You got all your vascular stuff, your dermatology
Yeah.
stuff, your sports stuff. I mean, the sort of youngest patient I've seen is 11 months old, and he goes,
Yeah.
and the wisest, I never say oldest, patients don't get older, they get wiser. The wisest is 113, and
Wow.
everybody in between, and we're
Yeah.
just looking at babies who are effectively babies at 11 months old. You're looking at congenital deformities like clubfoot, for example. Age 2, 3, you're looking at conditions like intoers, toe walkers, and your general pediatric red flags that we look through, as it were.
Yeah.
Severs is quite common that we see in sort of 7, 8, 9-year-olds, active pre-teens, as it were. Ingrown toenails, very, very common.
Yeah.
Verrucas, super common in that population. And as they get that bit wiser, you're looking at your 20s and 30s, looking at things like MSK issues, knee pain, shin pain, foot pain, etc.
Yeah.
As you get that bit wiser, you're looking at sort of more cause, callus, routine nails. Again, really important to keep people active. Then you've got all the sports issues coming in, then you've got all your diabetes care, and absolutely everything you possibly think of. So, if you've got a stroke patient who had a stroke and their gait has now changed, for example, what can you do to ensure that they're walking a bit more comfortably? Can you give them their independence back? Are they able to do more for themselves?
So important.
It's all them sort of things you've got to think about. And again, it's really thinking as broadly and laterally as you possibly can think. So yeah, that's the idea. So I mean, my sort of plea when it comes to the general public and to GPs out there would be, think feet, think podiatry. If you're not too sure, have a little chat, refer on, get to network with your local podiatrist, as it were, and kind of building these community networks, as it were, helps patients.
Yeah, and some of our referrals do get rejected, like I mentioned right at the beginning. And so then what do we do with those patients? If, for example, we do feel they need, things sorted with their feet, then what do we say, private care, or do we?
It would really depend on how you operate as a surgery and what the rules tend to be. Sometimes if you're sort of, you can't. Well, you could refer across to NHS, private practice too. Don't get me wrong, but it really depends. Sometimes if you pick a particular private practice, it can be frowned upon too. It's all about sort of just gauging all of them sort of things. But yeah, there are various things out there. You've got various charities out there, different support centres. I mean, even when it comes to like homeless care, for example, we've got a huge arm, a charity arm that deals with sort of homeless.
I didn't know that.
Homeless care. So my good friend Debbie Monk set up Forgotten Feet, which is a charity that sort of provides podiatry care to the homeless community. And I think that was absolutely brilliant. And we've got centres across the UK where qualified podiatrists go along to particular areas, and we sort of provide completely free care to the homeless community. So there's also that aspect too. So it's really quite broad ranging, yeah.
Yeah. And do you think, this is just me being a bit cynical, I suppose, not in a bad way, but when I think of podiatry, I think, okay, you're just thinking about the feet. I never really thought that you'd be thinking about the holistic side of things, because I have been in clinic and there's not much conversation about the general well-being of the person. Just, okay, you've got your bunions there or whatever, we'll sort them out. Just how are you, that sort of thing. How much, is this more in private practice that you get this opportunity compared to NHS, where the pressures are more, the appointment times are a bit stricter?
True. Well, it's a fair point. I mean, I'm a firm believer that any podiatrist worth their salt should look at that patient holistically, no matter what sector they live in, working for that matter. And yeah, you're right. In the private sector, you have a bit more time, so you're able to do all of that. But especially in part of the NHS as well, there's no reason why you can't pick up on these issues and signpost accordingly. Whilst I was in the NHS, we had one chap who was suicidal. And Friday, 3 p.m.,
oh my God.
me, life's not going too well. And he'd had 2 previous attempts on his life. And we're thinking, well, how long ago was that? 2 weeks ago. Oh dear, it's a real crisis now. And you're thinking, well, what do I do? So, referred him across to the mental health crisis team, got the vulnerable adults team involved, contacted his GP to let them know about what's going on. And thankfully, he's on the road to mental health recovery, as it were. But there's always things you can do, irrespective of what sector you work in. So it's about, and I make a point of ensuring that routine is never quite routine.
Yeah.
There's always more you can do. Let's have a chat about the patient's well-being. Are you living by yourself? Do you have family around you? What's nutrition looking like, for example? It's pressing that patient for as much as you possibly can, building a really good rapport with them. Once you have a really good rapport, they'll open up. The more they open up, the more opportunities you can do to actually help beyond their feet, as it were. But of course, the clinical aspect is really important to manage the presenting complaint of what they're coming for, but also managing everything else too. So when we're talking about diabetes in particular, and let's just say somebody's going through a diabetic foot check, for example. Let's have a little chat about your HbA1c. What is it? And often, they say, "Oh, I don't know." Well, how do you not know? It's just, this is your health. Oh, no one told me. That really annoys me, typically. I'm a firm believer. Everything I do, you explain in layman terms what you're doing, why you're doing it, what the results were, and where the normal parameters sit, and where they sit, on that scale, as it were. Because to be forewarned is to be forearmed. And the more patients know about their own health, the more empowered they feel to do something about it.
100%.
And I'm sure you totally agree with that in terms of being a
Yeah,
GP. Your kids do
100%.
that all the time.
Yeah,
And, you know, for me, it's all about giving them the tools to actually know what these are your feet, they're not my feet, as it were. I've got both my feet. Let's help you get yourself better, as it were.
mm,
You know, I've only got what 20 minutes, half an hour with the patients every
yeah,
how many weeks or how many months. I don't live with them, so let's have a little chat regarding what's your nutrition like. So you know, you're taking, you know, that's being managed by, you know, type 2 insulin dependent, for example,
yeah,
and HbA1c is 133 millimoles, it's 133 millimoles per mole. Okay,
that's,
something's not right here,
yeah,
you know.
yeah,
So it's no point pumping you full of more and more drugs. Let's have a little chat about actually the drugs you're using are obviously working, but that nutrition perhaps, you know, needs a bit of help. Let's refer to dietitians, for example. You know, how
mm,
often do we do that? We talk about good
yeah,
nutrition, but how often are we actually referring them out to sort of dietitians around
get some
us?
help.
Not very often, you know,
Yeah,
in my experience anyway. So it's all
mm,
about building that network of people. And yeah, so that's the idea behind it. Think of that patient as holistically as you possibly can. What more can
mm.
you do that's just beyond sort of their feet, as it were? What else can you do for that patient? How do you get them moving?
Yeah, I mean, when I'm in my clinic, I always make a real good point. If they've had bloods and they come in for blood test results, I go through each and every part of it and tell them the results. And if there's any red kind of exclamation marks which show an abnormal level of something, I will always explain whether it's significant or not, or whether it's what is it. Because you're right, patients should have the knowledge of what's going on, and then they'll be able to change their behaviors and adapt their lifestyle because they know how significant it is, especially HbA1c. That's a really good example. So you can tell them what the parameters are. And if they know they're like, oh my God, they're 80 or something, we need to get it down to like 53 minimum, or you know, maximum, then they've got a target to work towards. And especially I think the Asian population, you know, a lot of them don't know
Yeah,
like their HbA1c, they don't understand it. So I do actually try and explain even thyroid problems, you know, they don't know what thyroid is. They're like, what's a thyroid? I'm just taking this levothyroxine and
yeah.
I don't know if why I'm taking it.
Yeah, no,
So
I
it's,
totally agree. Absolutely. I mean, if you look at my sort of extended family, you ask them about their drugs that they're taking. I've taken a blue one, pink one, yellow one.
yeah,
Any idea what you're taking them for? Doctor told me to. And of course,
yeah,
he told you to, but do you know why you're taking them? No idea. And
yeah,
that's the issue. If you can't sort of begin to empower people, you can't change behaviours. And if you look at, you know, South Asian females tend to have the worst outcomes when it comes to health outcomes because they
mm,
really struggle to articulate what's going on, and often they're not
yeah,
taken that seriously, you know,
mm,
because there may be language barriers involved, for example. So it's all about being able to sort of manage that patient really well, whoever you've got in front of you. So
yeah,
if there's language barriers, we'll get interpreters involved. That's not an issue. And let's see what we can do to kind of listen to that patient and make them feel listened to. That's the biggest
yeah,
complaint the patient often have, that I got fobbed off or no one really listens to me properly. But if we can actually take the time, and I know it's pressure, we're all under pressure, of course we are. But my philosophy always is, if you're waiting, I'm sorry you're waiting, but when you get the chance to sit in my chair, you get the same amount of time as the last person. If it means I
yeah,
overrun and I overrun into my lunchtime, I don't go home in time. Well, that's my issue, you know.
mm,
But you know, other people are people. They're not. It's not a conveyor belt we got here. There's real people, real problems, real issues,
yeah.
and whatever we can do to help, you know, from our tiny little remit as a podiatrist, then absolutely. But and that extends to all aspects of health and all disciplines.
Yeah. No, it's nice to hear that because I feel like sometimes as a GP, like we get told we have to think about the holistic care of the patient. It's nice to know that in other allied health care professionals also do the same thing and can feed back to us to try and help the patient's journey going forward. I did have some other questions.
Yeah, go.
So, say for example, someone's considering a career in maybe podiatry. What advice would you give them?
I would say go for it.
Yeah.
I'm a bit biased, obviously. Now, I think
Yeah.
it's a fantastic career to go into. You know, there's so much more than meets the eye for the
Yeah.
reasons I've just mentioned, as it were. But you know, being a really effective communicator and a great listener is a real key part of the job. You know,
Yeah.
and if you think you've got that skill set, then brilliant. I mean, I always look out for soft skills if I'm looking at students in particular. If you don't know the content, the clinical stuff, that's fine. That's why you're here. You know, we'll teach you,
Yeah.
and you will learn that. What I can't teach you is soft skills. I can't teach you to be a great communicator. I can't teach you to be empathetic. You know, you've either got it or you haven't.
Yeah.
And it's that building that and honing that as time goes on. So absolutely, it's such a varied career to go into, as it were. And I would absolutely champion the profession of podiatry wholly.
Yeah. And in terms of people who are podiatry students, or what advice would you give them about a career in podiatry generally?
I would say hang in there.
Mm.
It's often a bit tricky. I was just doing a talk to first year students yesterday, actually,
Yeah,
just having a chat about sort of, just to get through university and how do we get through it. And these are the first years,
yeah,
few weeks in, I found it really overwhelming with lots of new terminology and lots of new content. And I was like, I promise you, you will get there. If I can do it, anyone can do it.
yeah,
And just guiding through that process. But I think the biggest advice I will give as well is building a good network around you and having
mm,
a really good team of people around you. And networking is a real skill because you could be
yes,
amazing at what you do, but if no one knows who you are, then what's the point? It's
mm,
about being able to share that with other people, but also helping each other. Different people work in different sectors, but the more you get to know other people, i.e. in the same profession or different professions, you think, actually, hang on a minute, I know somebody who can help me, or I know somebody who can do that. So if you
yeah,
want to go into things like leadership, management, academia, research, forensics, these are really sort of kind of out there, generally speaking. I think typically when it comes to podiatry, the sort of advice tends to be, well, NHS private practice. Well, there's so much more than
I
just
know, yeah,
that aspect of it.
wow,
There's so much more you can do. Have you thought about a career in research and academia? I would
yeah,
happily champion that. We don't see many coming our way. So, and we're struggling because once we have these pool of great academics retire, then who do you have to take over? So it's about holding that next generation of people, having that succession planning in place. So yeah, there's a really varied career to be had, and it's what
yeah,
you make of it.
mm,
So start off, as it were, hang in there. Knowledge is king or queen. You've got to know your stuff, and with that comes confidence, and with
yeah,
that then comes competence.
yeah,
And it's
exactly.
about going through that journey with people, especially if you're a student at the moment.
Yeah, and I think this can be applied to any career,
True.
so it's a very, very good advice. And in terms of just generally what you're doing this week, are you in clinic? What are you doing uh, at the moment?
I'm still in clinic at the moment. I'll be in clinic all week because I apparently live in the clinic. I might as well sleep there, to be honest. So yeah, I'm in clinic, but a number of various sort of meetings in the evenings, for example, different conferences, different committees.
Yeah,
There's always something going on in the background.
yeah,
It never
yeah,
quite stops.
yeah,
But yeah, it's always quite enjoyable to be honest. I mean, even in terms of my role on council in terms of Royal College, that's managing the sort of strategic direction of the organisation, and that's a 24/7 job really. That's not a
yeah,
Monday only job. You've got things coming in every single day that you have to manage and deal with, and yeah, it's quite
yeah,
enjoyable. You are at the sharp end of it all, and it makes a great opportunity. So yeah, I mean, my working week would be perhaps the same as yours really, because you're equally as
yeah,
busy as me, aren't you, Zainab?
yeah,
Spend a
just a
bit
little
of
bit.
time. So it's
Yeah.
always quite enjoyable. But yeah, but like I said, idle hands are the devil's work, as the saying goes. So keeping yourself busy is not always a bad thing.
And
Keeps
what
me out of
about
trouble.
advice? Yeah, yeah, exactly. And what about like GPs? Like, what would you want to say to the GPs that have joined the live or watching the live? Or
I would say is, just be familiar with what podiatry is, what we do, and understand how we can also help as well. I think because people are not familiar with what podiatrists do and what our scope of practice is, they often think, well, there's no point referring across podiatry because we don't know what they're able to do. So being
yeah,
familiar with all of that would be certainly quite helpful. But if you do get any referrals that are rejected, find out why. Go around asking, well, why has that been rejected? What else can I do for that patient? If you're not going to take them on, what do I do with them?
yeah.
And that's how you sort of build the understanding of what we do as a profession.
So think feet, think podiatry.
Absolutely.
Yeah. And then is there any sort of advice line? Do you know in the NHS is a bit like choose and book advice and guidance? We have.
Um,
Do you know if there's one for podiatry or?
Not a national one, I don't think.
Okay.
There would be individual trusts, depending on where you work in the country.
Oh,
Get to find out what your local trust is or where it is for that matter. They typically
yeah.
have a web page. Ring up that number. You can speak
Yeah.
to Miss Lees, and they'll be more than happy. And we're always looking to collaborate with GPs, often because we need to. The
Yeah.
two working hand in hand. It's a symbiotic relationship to kind of get patients better. So
Yeah.
the same is true for podiatrists. Get to know your local GP surgeries and get familiar with your practice managers, have a chat with them. And one thing I do all the time is sort of make a point of writing a letter out to the GP explaining what we've done, what the intervention was, for example, so that in the loop as to what we've done. So if we've done like a diabetic foot check on the patient and they'll come back as high risk, you know, it's important the patient recognises that. So it's important that the GP recognises that, and that also helps them manage their patient better as well. You know, despite working in the private sector, so the two go hand in hand.
Yeah, absolutely. I just want to end by telling you quickly about, like, every time I'm on call, I get at least one podiatry letter, at least. And it'll be about a patient that we need to refer onwards. And today, for example, we had one, and I wouldn't have even known about this, but this patient was having care with podiatry in the community for an ingrowing toenail, but it was conservative management, but then it was granulation. And now that it was going to be impossible to treat, so they want us to refer to secondary care now. And you just think, you know, along the journey, you know, they've now contacted us now to refer. And I appreciate that conversation, you know, that conversation, that dialogue. But I feel like maybe I should have known about that patient, or because the patient didn't come and see us, they were just under the podiatry pathway at that point. So yeah, it's important. I think maybe we should have the same system or some sort of easy communication. And so we know who's on the podiatry list, so we can kind of like see what's going on. But it's just hard, isn't it? The NHS is too...
It's really hard, because if you think, I mean, you know, here we are talking about podiatry, but speak about other HPs, speech and language therapists, dietitians, there'll be a whole host of things. And you're right, you know, we could improve relationships between each other, get familiar with what's going on, and share common knowledge. And that way, this is why I make a point of writing to my GPs, so the GP is aware. So if they do scroll through the letter and say, oh yeah, I got the letter eventually, and that will then make sense as to what that patient presented with today, as it were. So at least they've got our details, you know, if ever. But things like AF we pick up quite routinely as well, you know. So it's a case of, well, actually, you know, are you aware of that? Oh, no, never knew. Well, is your GP aware of it? I doubt it. So we end up doing a letter to the GP saying, well, actually, you know what, we've picked up AF. We have a little cardia mini ECG machine we've got in clinic as well that we can use. And of course, I'll be sent off for a full-on ECG, as it were, managed that way. So, you know, it's getting patients to recognise what we do, getting GPs to recognise what we do. And once you start doing that, you then tend to find that you get a bit of a name in the community that actually, hang on a minute, you know, this person knows what they're talking about. So if there are any foot issues or foot ankle issues, we'll start referring out that way. And that's how you start building that network up as well. Again, it works obviously both ways.
Yeah, absolutely. Oh, any other questions that do you have any questions for me?
I guess
I don't have any more questions, I think we've covered most of the questions that I had.
Good.
Yeah, so anything that you want to add before we...
I guess one question I would say is, you know, prior to today's live, as it were, and perhaps prior to speaking to me, would you say that your understanding of the scope of practice for podiatrists has improved?
Yeah, I'm just really like it's refreshing to hear that you are thinking in the holistic way. Is, you know, that you're dealing with a lot more than I just think, oh, you're going to be dealing with just feet and sorting the feet out, but you're having to think about lots of different things, because obviously all these conditions affect the feet in so many different ways. But I thought that we're dealing with the medical side of things, you're just dealing with what the presentation is at the end, you know. But no, you're doing a lot more, and I think, and I respect that, and I think you're right, we should have more of a dialogue and a bit more communication with our local podiatry team, so that we can communicate effectively and make patient care journey better.
Absolutely. I mean, in terms of improving that patient sort of access and journey and making GPs perhaps more aware, I mean, back in my previous clinic, what we used to do was actually I wrote to all the practice managers in the 5-mile radius to us, saying, are you familiar with podiatry? Do you know what we do? Do you know what our scope of practice is, etc.? And we went along to their GP training days and actually did a mini talk at their surgeries, and they absolutely loved it, because they're always looking for CPD, aren't they? And it was brilliant, you know. And you know, we learned a lot, they learned a lot, everyone was really happy. But of course, that all translates to improved patient outcomes, and ultimately that's what matters.
And sometimes when you know who you're referring to, can make it a little bit easier. You know, like, oh yeah, I know that person. I saw them. You know, they gave us a lecture, and you know, they know us and we know them. It just makes it so much easier.
Absolutely.
Sometimes you're referring, you just think it's podiatry, don't know who it's going to.
True.
So yeah, but thank you very much for that. That was very, very useful, and I'm sure people who will watch this back will definitely benefit from career in podiatry. Like Usamah said, go for it. There's a lot more to it than just feet. Lots of opportunities outside of podiatry, inside podiatry, but with that qualification. So Thank you very much for all that information.
Been an absolute pleasure, Zainab. Thank
Yeah.
you.
You take care now, okay?
Okay. Good night.
Okay, good night. That's the end of life.